ears. So we're just going to focus on that in this chapter. Okay, so what are the effects of aging on vision? Well, pretty obvious here. There is a problem of being able to focus. And so because we cannot focus, the elasticity in the muscles of the lens also changes, which causes a little bit more difficulty with seeing. The pupil size becomes smaller. So if you look at a patient, if you're doing your assessment, the perla, and if you're doing that, you'll notice that the pupil sizes of many of your older geriatric population is a little bit smaller than you would see in maybe a 30 or 40-year-old person. And of course, the lens start to become cloudy. And so usually what we see there is we're looking at some cataracts, and we're going to talk about those. So these things do happen as we age. Another thing that's important to remember is that the perception of light decreases. So patients need to have plenty of light to be able to move around. Mainly because in the retina, remember, that's where we see our the photosensors, receptor cells, and so they begin to get die off. It's hard for our older patients to adapt to light. For instance, if they get up at night and they don't have, and there's a little bit of light, say from outside, but they don't have a night light, it'll take them a little bit longer to get adjusted to that low level of lighting. And so they are at high risk for falls as well. Glaring is a problem for them, so we do remind them to be sure they're wearing sunglasses if at all possible. Depth perception. Remember when we talked about mobility, and we said when we step on a sidewalk, be sure that they put both feet together at the end of the curb before they step down, because the depth perception in a patient who is older is not as acute as it is for a younger person, and so it's a good chance that they could trip and fall because they don't have their perception. Coming downstairs or even going upstairs can also be a problem with that depth perception. And of course, we do the confrontation test. We do the peripheral vision, and so it will also start to become a little bit more reduced, and they cannot see. We need to know these things about our patient because we need to be aware of how we should interact with them. Okay. Sometimes, because they cannot see very well, or their perception of what they're looking at, facial expressions and gestures might be missed or misinterpreted. So we have to be careful with the use of our body language with our patients who are older, because they could actually mistake you for making some other kind of gesture. Who knows? Okay, their lip reading ability. A lot of patients who cannot hear, they tend to use lip reading, but even with the older population, that ability to lip read is reduced because of the age it changes in their eyes. Well, we're going to look at hearing. We're going to talk about some specific conditions in just a moment, but basically they have difficulty hearing, as you well know. It's very obvious. We do use hearing aids a lot with our patients now. Sometimes we have patients that come into the hospital who has impacted cerumen, which is your ear wax, and we might have to irrigate those ears. And patients who can't hear or even see, sometimes they feel so uncomfortable around other people, particularly the hearing, that they stay away from crowds or other people because they don't want to be embarrassed because they can't hear, and they have to keep leaning forward or turning their head or adjusting their hearing aid. So it can be a limitation on them and their socialization with other people. We have to promote vision. Of course, we always talk to them about routine exams, all right? An ophthalmologist is a good one. You can go to an optometrist, but an ophthalmologist is probably much better for an older person, simply because there's an increased risk of, your cataracts, and then there's macular degeneration, and there is, of course, uh, glaucoma issues with our patients. And so an ophthalmologist would be probably better for them because they do a lot different types of testing and much more in depth for our patients. We do want to make sure that they're treated as soon as possible or as early as possible once they begin to have some of these deficits so we can help them. We talk about insurances. Medicare doesn't pay a whole lot of money for vision or hearing. They'll pay some things, but they don't pay as much, so it could be a problem for them financially if they need any special equipment. So we have to look for ways, and again, our case managers and our social workers can help us if we're working in the hospital. Right. You must know these nutrients. Okay. All right. The first one is zinc. These are very important to know for helping to keep our vision healthy. Zinc is good for getting used to the dark or adapting to the dark. So we want to make sure our patients get plenty of zinc. Zinc can also help to reduce problems with our visual losses with macular degeneration. Selenium, definitely used for cataracts. Vitamin C can improve vision with cataracts. Let's see. Oh, there it is. Oh, I think vitamin A, wait a minute, go back. I think vitamin A is too far down here. I don't know if you can see it on this slide, but let's make sure you got vitamin A. Vitamin A is used to maintain healthy rods and cones in the retina. Vitamin A. I'll fix that later on. Okay. Some others that are important. Vitamin E helps to prevent cataracts. And if we give enough of it, it can help prevent macular degeneration. Riboflavin, again, cataracts. There's a lot of vitamins that help with cataracts, and I think that's important to know because it's such a common, prevalent thing that we see in our older patients and older population. Ginkgo biloba for degenerative changes, of course. Flavonoid improves night vision and the darkness as well, and helps to reduce some hemorrhaging from diabetic retinopathy. And patients who have diabetic retinopathy, they easily go blind because of the high sugar content in the bloodstream over time. It can lead to blindness. So these are very important vitamins to know, or not just vitamins, but of course your herbs. So arteriosclerosis, hypertension, diabetes, and nutritional deficiencies, definitely this is true, can threaten an adult's vision. This is true. Promoting hearing, really, it's a lifetime of taking good care of your ears, keeping the noise level down, protecting your ears from high noises. And so we can destroy our ears in our younger life because of the loud music and not protecting them. So it's important to remember that. We also want to make sure that we look into our patients' ears. You'll use your otoscope. I believe we did that in lab. And we want to check for any kind of major issues, infection perhaps, or maybe some earwax that has accumulated. We need to be looking into our patients' ears as well. So again, for us to be able to care for our patients, we want to make sure that we're able to assess the eyes and the ears, and we're going to look at that. I think you probably remember from health assessment when you inspect the patient, you can palpate the eyeball. Just remember not to press too hard on the eye because it can be a little bit uncomfortable. And you want to see if there's any major issues with that. We look at checking the gross visual acuity. The way we can do that in the clinical setting is to actually have a patient read a newspaper or menu, and if you notice that they're having difficulties with that, it could be the fact that they've had some issues with their eyes. Again, you can use the number of fingers, how many number of fingers you have, 1 or 2, 3. So there's other things that we can do, and we're definitely going to be assessing those extraocular movements. I think y'all probably remember those. Remember, there's 6 muscles that control the eye. We want to make sure that we are doing our wheel, or however you do it. There's 2 ways. There's an H and there's a wheel that you can determine and make sure you do an accommodation and those types of things with the eye. So that's just all part of your physical assessment for eyes. So we're going to look at 3 here, and we're going to talk about each one of these. These are the important ones for eyes: cataracts, macular degeneration, and glaucoma. So we'll talk about cataracts first. Generally, initially, there's no pain or discomfort from a cataract. The vision can become distorted or kind of blurry. Night vision becomes reduced with cataracts. Remember, it's actually where the lens becomes kind of opaque and you can't quite see clearly through it. Having difficulty vision from a distance is also a sign and symptom of that as well. The glaring problems, can't stand the light or bright light. And so the signs and symptoms generally are usually picked up if you are working in an optometrist, or if you go to say an eye doctor, just like an eyeglass, and not an optometrist. They can easily pick up the fact that if you have beginnings of cataracts. Cataracts can start early. It could be as early as 40 and 50 years old. It doesn't have to be an older person, but they generally can start earlier. And intense Florida sunlight can actually speed up the development of cataracts here in the state of Florida because of that intense sunlight. So again, those sunglasses are important. Some of the things that we can do to help our patients is to limit some of that light. We might want to suggest that they cover the windows with some curtains. We might have to use large print reading materials. Again, we've talked about sunglasses. And we want to be sure that if the patient does have a cataract in either eye or even both, we have to put the objects that they need, say their brush or their book or whatever it is they're needing, in the way that they can see it in their vision. Sometimes cataracts will start in only one eye. Sometimes it'll be 2 eyes. It just depends on the patient and what's going on with the patient. Another thing to remember is if they're at home, we're not going to rearrange the furniture, particularly if they have a bad case of cataracts. Because remember, removing furniture, they might have kind of memorized, the brain would have memorized the path to the bathroom. And if we accidentally move a piece of furniture and forget to move it back, or even in the hospital room as well, they could easily fall over that piece of furniture, particularly if they're at the great end stages. Nowadays, I've known a lot of people who need to have cataract surgery, but basically it has to be a certain size before even surgeons will do a cataract surgery. There's different ways of doing it. There's LASIK surgery now and all of those things, but it is a very, very common and really a fast process. Has anybody ever seen, like on YouTube, how they do cataract surgery? Have you ever seen it being performed? Maybe not. If you're really interested, and it's really one of the grossest types of surgery I've ever seen personally, it's awful because you're awake during the procedure. They may give you something to relax you, but you're awake during the procedure. You can see that they're coming towards your eyes with these instruments, and they cut out the cataract and they put in the fresh lens and all of those things. But it's a fairly quick procedure, and the patient usually goes home the same day. It's an outpatient surgery, and they begin to see pretty well. It could take several weeks before the vision really starts to clear up because of the manipulation of the eye. And I don't believe there's a lot of infection rates with cataract surgery, although I've known a couple that developed infections, but only because of their sterility and stuff. But cataract surgery is so common now, and there's many other types of surgeries that we can get for these different types of things. Glaucoma, which is on the other side of your slide there. If somebody has what we call acute glaucoma, there's a lot of pain, headaches, and nausea, and maybe even some vomiting can occur with glaucoma. The pressure in the eye can rapidly expand, and then it causes edema, and even the ciliary bodies begin to enlarge. And blindness, of course, obviously blindness can cause, this can cause blindness as well. If someone has chronic glaucoma, it's a little bit different. First, there's some diminished peripheral vision, like on the sides. They're constantly getting new eyeglasses because they can't quite see, so they keep going back to the doctor. And then eventually central vision begins to diminish as well. These patients will have headaches, fatigue, visual fatigue. Their eyes will get really tired easily. Then they might complain of looking, and it's kind of misty looking, and they get these halos around the light, and it's worse in the morning. It is routine now when you go to an eye doctor that they check for glaucoma. And there's a certain pressure, and we won't go into that. So they definitely do a lot of pre-screening for glaucoma because of the danger of it can actually going into blindness. It's the second leading cause of blindness, as you can see there. For nursing interventions with glaucoma, a couple of things to kind of remember. We want to limit the pressure or the intraocular pressure. So in other words, no straining, no leaning over, no stress of the eye. There's lots of eye drops that the glaucoma needs to take care of that eye. Unfortunately, the optic nerve is basically damaged because of the increase of the ocular pressure, or intraocular pressure, I should say. 12% of all blindness is in this population. 12% of people in general have been blinded by glaucoma. Usually it is over age 40 because it's a progressive condition as well. Women are more affected, as well as African American people, individuals at an earlier age. So women in earlier age. I had actually a high school friend. I'll never forget this. This poor girl, she was my high school person that I went with, the high school. She was a very good friend of mine, and she actually developed glaucoma, and she was only like 17 years old. She had some terrible problems with glaucoma, and by the time she left high school, she was almost totally blind from the glaucoma. And back then, it's been years ago, obviously, they couldn't do a whole lot for her. So she lost much of her vision because of glaucoma, developing it at such a young age. Okay, and it does occur from time to time. There is a nursing care plan on page 371. It's the older adult with open angle glaucoma, which is a really good care plan as well. So be sure you kind of just glance through that to see some of those nursing interventions that you could do to help with glaucoma. And the last one on here is macular degeneration. It is the most common cause of blindness in adults over the age of 65, unfortunately. There is diminished vision in portions of the visual field. Some areas have some clarity of vision. Some areas do not. It's unfortunate. But we do know that this can happen, and it is the most common cause of blindness in anyone over age 65. So for us as nurses, we would want to do some nursing interventions, such as making sure that we make sure our patient's head is turned so they can use that the good part of their eye so they can see. Sunglasses is always an answer, okay? Making sure the house is safe if they're at home or their hospital room because they can fall, and all of those things. So macular degeneration is a really serious problem. So which type of visual problem is associated with macular degeneration? Anyone to tell us that? Which is most associated with macular degeneration?
A.
It's actually loss of, yeah, it's B. It's loss of central vision. It's loss of the central vision, absolutely. They do have some peripheral issues, but the worst part of this is really the central vision where they can't see. All right, so this is it's unfortunate. And there's been some people you may have known who've had macular degeneration, and it just slowly goes, slowly dies their eye, it kills their eyes basically. All right. Detached retina, nobody likes these. Even young people can have detached retinas. Severe sudden blows to the head or to the face can actually detach the retina from the back of the eye. That can be a gradual or sudden loss of vision, perception of spots before the eyes. We call them floaters. They start seeing these little black floaters, floating around in their eye. They think they see something, and then they look around and they don't see anything moving in the air, but it's actually these little pieces of tissue that are moving around inside the eye. That's what we call floaters. Of course, the vision becomes blurry. Sometimes there's flashes of light with someone with a detached retina. They sometimes tell us that there's like a film covering their eyes. It's gradually covering their eyes and they're having difficulty seeing. And detached retina is usually painless, right? Usually painless. Okay. So what can we do to help them? Of course, obviously, because the retina has become detached, it could be one or both eyes. We need to keep the patient as calm as possible, help them to rest. We might need to be putting on bilateral eye patches to kind of keep the eye from straining until the surgeon can reattach the retina to the back of the eye. They've done lots of improvements in the fixing of a torn or broken retina or a detached retina. I do know a person right now who, I guess 5 or 6 months ago, had noticed the floaters, those little black spots. And so she went to the eye doctor and discovered that she had a detached retina in, I think it was her, yeah, it's her left eye. So she went to surgery and so they could fix it. And then she developed an eye infection from the surgery. And then what they do is they put in a special bubble of either oil or water. It's like a little bubble to help keep the retina in place. She had issues with that. She couldn't drive for long periods of time. She couldn't drive. And at night, she definitely wouldn't want to drive. Her vision, she had to go back for another surgery. They switched out to the oil bubble to put in a water bubble, which also helps keep that. There's two types, and her vision is somewhat improving now. But unfortunately, she can drive during the day, but she still can't drive at night. But that's from a detached retina. So there can be some post-operative surgical complications with this particular condition. The patients can become confused, particularly if their vision has become decreased. Remember, they are going to have some type of sensory deprivation because they can't see, and so they might become confused from that. That could also help. So keep them calm, be calm in their presence, and make sure they can get to a call light. And then, of course, they'll go to surgery. All right. Prompt treatment is necessary in this case. A lot of material on the tip retina. Here's a corneal ulcer. Corneal ulcer. This is another type of problem. Basically, it's the, if you'll see, you can see the pictures here of a corneal ulcer. You can see both of those. It's like a little whitish spot in the eye. Usually the eye becomes bloodshot or reddened, and you can see that's for both of these. You can see that little bit of inflammatory piece in the eye on both of those pictures there. There is pain with a corneal ulcer, and of course it can cause blindness, of course. Photophobia, having difficulty with lights shining in their eyes, can also be an issue with them. And usually increased lacrimation, which is increased tears, can occur with these corneal ulcers as well. They'll have a lot more tears. Again, we want to make sure with a corneal ulcer, they tend to go to the doctor too, and they can do an ultraviolet light, put the medication. It's usually a kind of a yellow medication that they put in the eye, and then they shine an ultraviolet light, and it can actually show any kind of abrasion or even even better vision of this corneal ulcer. But we want to make sure that they have warm compresses because it's very uncomfortable. It's very painful. Sometimes the doc will order some antibiotics just to keep it from becoming infection, and even giving them something to sleep. Generally they heal, but it takes a long time. Okay. Generally they do heal. Okay. So those are the main pieces of your eye problems, but there's a couple things on hearing deficits that we need to look at. And there's some terms up here. Be sure you know tinnitus. I'm sure you remember that. Ringing of the ears. It can be caused by many things, including aspirin. All right, so that's something important to remember. Inner ear problems, lots of things can call up. They might have an infection. You know, they can have a vascular problem in the brain. However, there are risks for hearing deficits, like exposure to noise, as I've mentioned, recurrent ear infections over and over again, trauma, and I actually mentioned aspirins and the mycins. The mycins, M-Y-C-I-N-S, that group of drugs also has some problems with hearing. Gentamicin is one, you probably remember that, ototoxicity. Okay. There is some inner ear damage sometimes from infections, and particularly if they're not treated. But middle ear is not common. The middle ear infections are not really common with the older population, but they can develop the otosclerosis, which is more common for them. Okay. Otosclerosis is like a little bony growth in the ear, and that actually is more common. The issue with hearing deficits, very kind of similar to your visual deficits, is that because the patient can't hear, they're going to be socially isolated, become depressed. There is an increased risk of dementia. You know, they're not stimulated, so they're not going to, they're not going to be around people very often, or don't want to be. There is a higher mortality rate. Isn't that interesting? Because a person has a hearing deficit, a higher mortality rate. You can imagine why. Maybe they are walking down the street and they can't see a car, or they can't hear a dog barking and maybe the dog attacks them, or when they're driving, they don't hear a car horn. If they have visual disturbances already, they may not be able to look at the red, green, and yellow lights. Maybe they have some color problems. So things can happen not only with the vision, but also with hearing. A person who can't hear, sometimes they can become very angry and frustrated, very impatient, confused, and they definitely have a limited ability to identify any type of danger, and that's one of the major issues with that. So hearing aids are things that are very common now. We can see them, but we need to be able to improve our communication with someone who has a hearing deficit, whether it's a hearing aid in use or not. So remember to really talk slowly, use a low tone of voice because the older population can hear the low tones much better than they can hear those high tones when we talk to them. We want to be very distinct and clear on how we speak. We don't want to raise our voice. We can talk into the less impaired ear if we need to. Be sure we face the patient, use sign language and gestures, our facial expressions, and of course, as you're well aware, with all the COVID and the wearing the mask, facial expressions a little bit more difficult. So you can imagine someone who does have hearing problems and they can't see your face to read your lips, how frustrating that can be. We can use all kinds of things to communicate with them. Just a brief thing about hearing aid care. Your book does bring out a couple of things. Just to remember that, I don't know if you've had an opportunity to help take care of somebody's hearing aids, but generally we need to turn the hearing aid off or remove the battery when it's not being worn because it could wear it out. And it has a special container that's padded, so it helps to protect it. Generally, it's cleaned at least once a week. And we don't use alcohol. Don't use alcohol on the hearing aids because it can damage the internal parts of that. It can cause some dry, alcohol will dry and cause things to crack. So you don't want to use that on your hearing aids. If a patient has hairspray, uses hairspray or any types of gels, we want to make sure that they do all of that before they put in their hearing aid, because that the spraying of the hairspray or the putting the gels on can actually mess up their hearing aid and it doesn't work. Okay, so be sure that they do that. And we also want to make sure to remember that keep it from extreme cold or extreme heat because of the danger of cracking it. So that's really all you need to know about a hearing aid. Changing the battery, of course, we're always going to do the aids first. There's new batteries out there on the market. Your book just mentions a little bit about keeping several new batteries available. Makes sense. And of course, the battery, according to your book, is to last about 80 hours. But again, it depends on the maker and the model of the hearing aid. And there's so many new ones out there, and they're very expensive. However, there are now some new ones that are coming out. They're only 3 digits of numbers instead of 6 digits. So hearing aids, and you can really only get a hearing aid with a prescription. All right, so something to think. So when we talk about sensory deficits, we talk about more than just hearing and vision. But these are the two most common for our older population, other than the taste, sensation, and those things. So how can we help them? Well, you remember way back in fundamentals, we talked about a variety of flavors and color for the diet to make the food look good enough to eat. Lots of flavors to stimulate that sensation, those appetites. Fresh flowers, as long as they don't have any neutropenic problems. Scented candles are good. Perfumes, that helps to stimulate their ability to smell well. Coffee, smells, fresh smell of coffee and baking is also very stimulating to our patients. Different textures, remember touch is also a sensation. So different textures of material, soft material, hard, the different types that we could use with our patients, particularly if they have difficulty with their touch. And sounds such as clocks and music boxes and chimes. There's lots of things that we can do just as a nurse to be able to stimulate some of those sensory problems. Okay. So in this one, I also give you a clinical scenario to take a look at. Okay. All right, this patient has macular degeneration, and she hurt herself, she fell. So I gave you some what if questions. So I think it would be good for you to kind of answer these questions for testing purposes. They're really good. It does give you just a kind of a review of what we talked about in this chapter. So just take a look at that. most of the material is on our PowerPoints anyway for you. Okay, so just take a look at this clinical scenario. I have some scenarios that'll be coming up in some of the later, in some more chapters that we actually will work together in class, but these last two, I'm just going to have you work them at home. Okay, so any questions on a quick review of sensory hearing, particularly hearing and vision? Any questions? Okay. So I think we're going to start one. I think we're going to start. So we finished all of week 3. We're all done with that. So we're going to look at digestive and bowel elimination, go over what we can, and then we're going to call it a day. All right. So let me pull that one up. And we will just continue on here and get some of these finished. By the way, next Thursday, or this coming Thursday, we're going to talk about the respiratory and circulatory system, which is a really, it's much more intense and massive, of course, because it's one of the two most important assessments that we do have is respiratory and circulatory. We'll talk a little bit about the endocrine functioning as well. And we'll probably, and we're also going to have to do urinary elimination, which is fairly short as well. So we'll do some digestion and bowel elimination in conjunction with our nutrition that we talked about today. Okay. All right. So that's chapter 20. So if you have that available, or I'm going to pull it up mine now. Okay, whoops. Oh, wait. I think I'm pulling it up. A second. Oh, there it is. It's gone. Okay, so let's take a look at this last chapter of the day. Digestion and bowel elimination. That's what we're going to be looking at now. Kind of far cry from neuro and sensory and all of those things. Okay. All right, so we'll spend just a little time on this, and then I'm thinking of maybe letting you go a few minutes early today because I know you are thinking about your EKG exam, and I want you to be able to be relaxed before you have to go take that. So let's spend about 15, maybe 20 minutes on this one, and then I'm going to release you to get some good hydration and some good nutrition, okay? And I got to get some water because I'm losing my voice. All right. Well, let me ask you this question since we're talking about EKGs. Which one of those EKGs would be a flat line? What's that called?
Asystole.
Asystole. Yeah. Which one looks like a picket fence? Now remember VTAC? Yeah. What does AFib look like? Y'all know this. I know you do. You studied. What's AFib look like?
QRS with a bunch of squiggly lines.
It's got a lot of little squiggly lines in there. Yep. Okay. All right. We're going to go over some of these in senior seminar, but I'm just trying to think. I don't have all your stuff here because I don't teach your class, but I just thought I'd ask. Sounds like you're doing well. Okay. All right. So digestion and bowel elimination. Oh, do you know what a couplet is?
Yes.
What's a couplet?
2 PVCs in a row.
Yeah. You know, when you get to 3 PVCs and above, what's the problem? What are we worried about?
VTAC.
Yeah, it ain't looking good. All right. Some people have, PVCs and, maybe 2 here and there, and maybe 2 here and there. But when it gets over 3, when it gets up to like 6, we're in serious trouble. We better be ready for emergency situation. So PVCs, not really happy to have those. So digestion and bowel elimination. So let's take a look at that. I'll have to move away from EKGs now for a short time. Okay, so again, I'm sure you remember as much as you can remember about the GI tract, ingestion, and how it's important for nutrition, since we did discuss that today. So I won't read this to you. You can read it. Okay. So what are the effects of aging on the GI health? Well, a couple things. Dental problems, as we heard this morning, altered or diminished taste, which we just talked about. What does the term, well, let me ask you, what is the term we use for dry mouth?
Xerostomia.
Yeah, xerostoma. Xerostomia, yeah. That's for dry mouth. Important term to remember. We know from our wonderful discussion today that there is decreased motility in the older population. The stomach becomes more alkaline. Of course, constipation is a problem. Gallstone formation is also an issue for the older population. And because of that, the inability to digest fats, that's all affected by the gallbladder, right? And so that can be a problem as well. So all of these alterations can actually impair nutrition, and there is going to be a greater chance for aspiration and dyspepsia. Okay, dyspepsia. The esophagus.
Sorry.
I'm sorry. Go
Did
ahead.
you say the stomach acid becomes more alkaline?
Yes.
Oh, okay. For some reason, I thought it became more acidic, and that's why they have like more GI issues or something.
It becomes more alkalinic. Yeah, it doesn't become more acidic.
Okay, thank you.
Yeah, they don't digest very well. Yeah. Think about the muscles. Remember we talked about musculoskeletal, and we know that the muscles fibers can begin to atrophy a little bit for many reasons, but that will affect the esophageal contractions. Because why? Why is there a relationship there? I want everybody to swallow. Did you swallow? What is the relationship between musculoskeletal problems and esophageal contractions?
Is it a muscle? So it's not as strong to squeeze it down?
Absolutely. You have reduced esophageal contractions because of the weaker muscles. And of course, remember we talk about aphasia and risk for aspirations and all of that? Many times it's because the muscles are so damaged by the stroke. Okay, so important. So we know that the esophagus takes much longer time to get the food down to the stomach. So because of that, they can feel like there's food lodged in their chest. Have you ever eaten a big hunk of something and maybe you swallowed it, but you kind of felt it go all the way down? Well, think about an older patient who already perhaps has aphasia, maybe perhaps has had a stroke, or even just an elderly person who has got some muscle issue going on. They may feel that. So it could simply be because of the slower transport of the esophagus muscles. Unfortunately, it can cause an increased risk for what?
Good.
Well, yeah, it definitely can do that. What about aspiration?
Aspiration?
Yes, absolutely. Great, Yuma. Yes, because the food is kind of stuck in the back of their throats, and there's a good chance because of the muscle issues that they can aspirate. And don't forget your aspiration precautions from way back in fundamentals. Tuck the head, tuck the chin, those types of things all right, for our patients if they have these issues. But lots of issues can affect aging, especially these types of issues. And I think I've talked a lot about that here. Okay. Notice here, and I think somebody asked me the question, the stomach has a higher pH. Higher pH means it's more alkaline because there's less hydrochloric acid and pepsin. Did that answer your question? I think somebody, whoever that was, asked me. I don't know who it was.
Yeah, I did. I had it backwards.
Yeah, and it's easy to get it backwards. I mean, I can understand why, because we think about, oh, they're going to have too much acid, they're going to have more GERD. Well, GERD is not necessarily, it's related to that, but they're going to have some hydrochloric acid. So GERD is a reflux. And so no matter how much acid they have on their stomach, little or a lot, they're still going to have some burning sensations and dyspepsia, right? Yeah. So always remember, stomach has higher pH. In other words, it's more alkaline. And so they don't do what? They don't digest their food real good. Okay. All right. They do have an increase in, of course, the gastric irritation, which we just kind of mentioned. And because there's not enough of the hydrochloric acid, sometimes their stomach and their gastric problems can cause calcium and folic acid and some other vitamins are not absorbed as well. We need pepsin for the absorption of protein. So if we have less, so when an older patient eats a lot of protein in a meal, it's going to take forever for them they will have a lot of gastric delay emptying that stomach. And because on the intestinal wall itself, you can see that there are fewer cells on the surface of the intestine. So that would change the ability to absorb certain elements such as dextrose, which is sugar, vitamins B and D. So lots of effects on aging in the intestinal tract. And here's more. It just goes on and on. This is terrible. Because everything is slower, as you can see, and there's a reduced activity many times in our older population. Again, these are generalizations, not specific to every individual. They don't drink as much fluid, and they take so many drugs, and they have a low fiber diet. Well, constipation can be a problem. Okay. Again, here we bring in the sensory perceptions, the taste, those types of things can lead to constipation. Okay, even sensory issues can have a problem. Gallstone, we've already talked about that there's an increased risk of gallstone development. And of course, the pancreas changes, everything changes, okay, in the older adult. And it affects our digestion of fats as well. Lots of things going on with the GI tract. So obviously, the discussion we had on nutrition today is so important because we know that there are many, many effects of aging based on our decline in the GI tract. So it's a really good segue into this. It's really good. Of course, we do want to do some health promotion. Our class mentioned that this morning. Good dental hygiene, regular visits. I won't repeat all of that information. Know those medications, which was great to discuss this morning as well. And, using like Senna. Senna was a common one as well. And utilizing fiber. Prunes are really good. Raisins, those types of things for get things moving. So there is an assessment guide for GI function. Just another quick review of your assessment guide. I'll let you take a look at that. Just remember, you're going to check for your GI tract. You're going to check your lips. You're going to check the oral cavity, because remember, the GI tract begins at the mouth. You got to check them teeth. You got to check the lips, their cavity and their tongue, their pharynx. You do your abdominal assessment on these patients. Rectum and stool, all of these things you're going to be checking on. Of course, their general appearance, their skin condition, what kind of odors they have about them. You know, what is the odor of their stool or their body odors? We always talk to them and interview them and ask them about their teeth, if they wear dentures, how's their appetite, of course. And of course, the patient will tell you any symptoms that they might have. Okay, remember, there's a difference between signs and symptoms. Symptoms are the things the patient generally tells us, and signs are things that we can see and measure. Okay, so that's a really, really good assessment guide for you. So xerostoma, what can we do about it? We've already said that it's got decreased saliva. Some medications can cause it. There's a syndrome, Sjogren's syndrome, which is dry mouth. We see dry mouth in patients, remember, with rheumatoid arthritis. We talked about that earlier this morning. They tend to have a terrible time with dry mouth, xerostoma. Mouth breathers also tend to keep their mouth open, and so when they breathe in and out, it dries their mouth so badly. Okay, and of course, cognition will affect some of this dry mouth as well. Right. So there's decreased saliva production in the older adult. So we could have saliva substitutes. They actually create those. They can make those, and they come in little tubes that they just put it in their mouth and helps to keep their mouth wet. A little bit of water, sugarless candy, and a little bit of gum also can help with that dry mouth. So which intervention will promote saliva production for the older adult living with dry mouth? Everybody should say what? Everybody knows this one? Will promote saliva production. Yes, D, sucking on hard sugarless candy, absolutely. Obviously, we know with diuretics, we're going to have an increased risk of dry mouth because of the dehydration potential. Daily oral hygiene is important, but that will not promote saliva production. It's not going to cause saliva to occur. And we've already talked about those lemon glycerin swabs, which is our no-no for all of our patients these days. All right, but definitely sugarless candy. We always say sugarless because, you know, we don't want them to have that extra sugar. Okay. There were some dental problems also discussed this morning as well. Periodontal disease is a very unfortunate problem, with particularly baby boomers, particularly those who did not grow up in a world in which the dental services were started at a very young age, which like they are now. That's much better now. Sometimes they have these problems because their diet, maybe they're on a low budget diet. It's mostly carbs because carbs are cheaper than, you know, fresh fruits and vegetables and some good meats. Maybe they're taking in a little bit too much sweets, which could cause dental caries, of course. Vitamin B complex and calcium can be deficient in our older population. Dilantin. What do you know? What is a main thing that dilantin or phenytoin can do? What can it cause in the mouth? Important to know, class. I can't hear you.
Gingivitis?
Yeah, gingivitis. Very good. You got an A on that one. Absolutely. Antihistamines can also cause dry mouth, but we definitely want to remember that phenytoin or dilantin can cause gingivitis. So be sure you're checking those patients' mouth if you're giving dilantin, okay, or phenytoin. Okay. Another term that you're familiar with is dysphagia. All right, they having problems swallowing. Lots of things can cause it. And you want to think about what are some of the signs and symptoms that you would expect for a client who has dysphagia. If you have a client, we talked about this way back in Fundies, and I'm sure you've seen this on your patients. If you have a patient who has dysphagia, what would you see in that patient, observing that patient, that would give you an idea that they got a problem swallowing?
Holding the food in their mouth.
Perfect. Yes, absolutely. Holding the food in their mouth. What else? There's a big one.
Spitting it out.
Excessive, like,
Is it drooling?
Yes, excessive drooling, spitting the food out. Uh, Even choking could be a problem. Or if they start kind of coughing a little bit, we have to be very careful with that as well. And so how can you reduce the incidence of choking and aspiration with a patient with dysphagia? What are some of the things? Give me about 3 things. There's many, many others, but what about 3 things?
Change the consistency of their food.
Absolutely. It should be thickened. Absolutely. That's one.
When they're swallowing, they need to tilt their head forward.
There you go. That's the second one. If you're feeding someone,
They should be sitting upright with small bites.
small bites, upright, and if they do have some kind of deficit on one side of their face or the other, you want to make sure that you put the food, small pieces of food, on the side that is stronger. Okay. Y'all are remembering all this great stuff. All right, so that's all I'm going to talk about that. So which medical problem may result in dysphagia?
Parkinson's.
Which medical problem? Is it hypertension, GERD, osteoporosis, or diverticulosis? And somebody actually said it earlier.
GERD.
GERD, yes. GERD can result in dysphagia. Always bringing up that esophageal reflux, burns the esophagus, right? A lot of GERD can cause a lot of aspiration issues. That's where we want them to sleep in an upright position, of course. I'm sure y'all remember that. Okay. Okay, I got a question for you here. A client complains of recurring heartburn, a sour taste in the mouth, and hoarseness in the throat. Identify the location of the structure of the GI tract in which these symptoms occur. If you had a pen, where would you mark it?
Your esophagus.
Okay, let's look. Yeah, see right there. Very good. It's right as it comes out of the stomach, right? And this area actually, let's see if you can see it. This area right here is also where we can see like Barrett's esophagus. You remember that one where there's a potential for cancer, particularly from GERD or some other things. That's where we see it in this area right here. It goes through the cardiac sphincter up into the esophagus. So that's where the structure, where the location would be for most of those symptoms, because it's coming right through here from the stomach through the cardiac sphincter. What's the name of this sphincter class that's down here at the bottom as it goes into the small intestine here? What's the name of that one?
Pyloric sphincter.
Yeah, pyloric sphincter. And what happens in little infant children, especially the little boys when they're first born, maybe they're just a little few months old or less. What do they call that? When they have projectile vomiting and they lose a lot of hydrochloric acid.
Stenosis.
Caloric stenosis.
Pyloric stenosis. Very good. Ooh, y'all been studying. Awesome. Cool. Y'all ready to go take the NCLEX soon? Yeah. Yeah. I can see it in your faces. Yeah, absolutely. Okay. All right. So I think what I'm going to do, it's 12:36. I think I can cover these few things next week. On Thursday. So we're going to start with a couple of the issues. We're going to do hiatal hernia and some esophageal cancer and some peptic ulcer disease. Just a quick review of that. Some diverticular diseases, something simple, colorectal cancer, constipation. And I've got you some activities within there, and I want to spend the time and go through those activities. So I think what I'm going to do is, first of all, is to tell you that it was great having you today. And I totally enjoyed the presentations. It was excellent presentations. And that, does anybody have any questions about anything you've studied today? No questions? All right, so it's 12:37. I'm going to release you to study nutrition, okay? Go get some food, get some rest, and get ready for your 2 o'clock. I will see some of y'all. I guess I'll see all of you because I'm going to be doing the 2 o'clock proctoring with you. But I will be here in class until 1 o'clock. So in about 15 minutes or so, I'll still be here in class. But I'm going to allow you to go and get some refreshments before you have to take that test. Right? Any questions? You're welcome. Any questions for you? I mean, from you. We've covered a lot of material today. All right, a lot of material. Review material.